for the age and the other is based on performance measurement as rated by the therapist. That is called KHI. Both the KHI and ADOHAN have been widely used in clinical trials in stroke rehabilitation. However, their relative merits warrant study in order to allow careful selection of outcome measures in clinical trials. Our comparison of both measurements found that there was a strong association between KHI and functional arm use of the patient. However, change in the patient-reported ADOHAN questionnaire was more sensitive to change in affected arm use after stroke rehabilitation. Both measurements may be used to complement with each other. There also remains a need for the study of the validity of the measures of more bilateral upper limb functions that may predict treatment success in daily functions involving bilateral arm activity, such as dining, bathing, transportation, money management, and so on. Cognitive status is an important determinant of treatment success in rehabilitation. The Montreal Cognitive Assessment is a widely used assessment in rehabilitation trials. There is a Taiwanese version of the Montreal Cognitive Assessment, abbreviated as MOCA-T, that has been widely used in Taiwan. Based on a cohort of 114 people with first ever stroke who received rehabilitation interventions, we look at both the relative and absolute reliability of the MOCA-T. The relative reliability can be assessed based on traditional statistic methods such as the inter-class correlation coefficients. The absolute reliability could inform us about the real change that is needed to identify the patient as gaining improvement over time after treatment. Methods that have been used for the estimation of absolute reliability include the standard error measurement, the small distribution difference, the SRD percentage, and the brand organ method. The ICC analysis established the reliability of the MOCA-T. Our use of the indices of the absolute reliability indicated that a 2-point change might be considered as a threshold of true change based on the indices of our calculations. In this study, we found that research on the MOCA-T in stroke rehabilitation is much needed in order for us to consider the relevance of ecological validity and cultural sensitivity the people in Taiwan who suffer from stroke. Motivation is another important psychological factor that may affect stroke rehabilitation. Self-efficacy is defined as patient confidence and motivation in their recovery from stroke. Self-efficacy has been associated with functional outcomes and is important for psychological therapy during rehabilitation. But there is a need for a sound measurement of self-efficacy. Also, there's a lack of research on the kinematic properties of the self-efficacy measurements. To address the problem, we have chosen stroke-specific self-efficacy questionnaire for study in our stroke patients. We are trying to establish the concept of validity, responsiveness, minimal detective change, and minimal clinically important difference, which are all important in traditional statistics to identify sensitivity and change in patients at the population level. However, stroke rehabilitation is individually tailored. There's a need to consider change after therapy at the individual level. Conditional LDC, which has been established as a measurement of the threshold of meaningful change at the individual level, has been cultivated in our study in order to inform interpretation of change after therapy at the population and at the individual level of the patient receiving stroke rehabilitation. It is recommended that conditional MDC might be included to complement the more conventionally used MDC and MCID for better interpretation of change in stroke rehabilitation trials. David Lin at Harvard University and Stephen Kramer at UCLA and their colleagues have proposed several new directions for treatments targeting stroke recovery since 2018. For example, Edward Tao established constraint-induced therapy, also called the force-induced therapy in 1993. Ramachandran and colleagues and Elbischer and others in 1999 proposed the use of neurotherapy for motor rehabilitation and pain relief. Stephen Hede at the Berlin Clinic proposed mechanical robotic training to facilitate motor recovery after stroke in 2003. Buchanan's approach, which refers to the use of virtual reality, augmented reality, mixed reality, and other gaming interventions, have been called the Buchanan approach since its inception in 1978, and more recently, during the pandemic of COVID-19 in 2020, VR, AR have become popular in home-based practice for patients with stroke. Also, telerehabilitation is important given today's medical system and the distance between the patients who need medical health and the medical settings. Telerehabilitation has been implemented in several areas in Taiwan since the pandemic of the COVID-19. Stroke rehabilitation can be divided into two different approaches. The unilateral approach is defined as the training that focuses on the affected upper limb or lower limb during motor rehabilitation. It is meant to minimize learned non-use or disuse of the affected limbs. The bilateral approach refers to repeated practice of bilateral movements by the upper or lower limbs during practice. It might be used to activate motor innervation in the brain and allow the coupling of both hemispheres to foster recovery from stroke. Examples of unilateral approaches include constraint-induced therapy, hemiplegia therapy. Bilateral approaches may involve bilateral arm training, near therapy. Of note, robotic therapy and near therapy are versatile. Both regimens can be shifted from the bilateral approach to the unilateral mode or vice versa. Therefore, they are very useful in clinical practice of stroke rehabilitation. We have tried to focus our work on mirror therapy, what it is, how it works. Mirror therapy involves the use of a mirror to create the illusion of movement of the affected arm. When the patient was asked to practice with his unaffected arm and look at the mirror for the reflection of the affected arm movement. The problem is that in conventional therapy, the patient might not be able to focus on the mirror given the distraction of the movement of the unaffected upper limb. To overcome the problem, we have used a small tray that can be used to hide the sight of the practicing arm during mirror therapy, so that the patient's attention can be directed toward the mirror to observe the mirror image, so that mirror therapy might work. Again, mirror therapy are versatile that can be used unilaterally or bilaterally. for the unilateral immunotherapy, only the blue circle, the unaffected upper limb moves, whereas the red unaffected upper limb remains static in the mirror box. The patient cannot see the unaffected arm during the practice. Unilateral MT can be implemented with daily activity tasks such as a mop or meal movements. Bilateral immunotherapy involves bilateral arm movements. The unaffected arm moves, whereas the affected arm moves in an attempt to duplicate the unaffected arm based on the mirror image observed during practice. In our comparative efficacy study of the combination of robotic therapy and conservative therapy and other movement therapy revealed that the bilateral approach to hybrid regimens might lead to better benefits in upper extremity mobility than unilateral approach, and control therapy involving robotic therapy might actually dose. Furthermore, bilateral hybrid approach might render better retention of treatment gains over time relative to the unilateral approach and the control approach at 3-month follow-up. Inspired by the finding of the merits of the bilateral approach to stroke rehabilitation, we move ahead to study bilateral robotic therapy plus bilateral movement therapy as the experimental group, as compared to the comparison group of bilateral robotic therapy plus bilateral arm training without mirror visual feedback. The control group involved the use of bilateral robotic therapy and training for movement impairments. The result indicates that robotic therapy plus mirror therapy has the most advantageous effect in improving motor impairments as compared to the other groups. The treatment effects were retained at 3-month follow-up. The findings indicate that robotic therapy and mirror therapy hold promise for combination with each other and with other regimens, such as gamma intervention like the VR or the AR, to allow interactive interest between the patient and the practitioners. To address the need for rehabilitation technology, we have moved from contemporary approaches based on hemiplegia therapy toward technology-based rehabilitation, such as non-invasive brain stimulation, contemporary robotic therapy, computer-assisted therapy, VR, AR, and Google Meet-based monitor or home-based, which is a part of our telerehabilitation system. In our efforts to establish the telerehabilitation system, we have moved from WhatsApp to video conferencing on Google Meet. The patient was instructed to practice mirror therapy in augmented reality at home via video conferencing on Google Meet, whereas the therapist can monitor patient practice at home, at a hospital, or at a lab. Then the therapist provided online or offline feedback for the patient to improve their practice strategies. Extra gaming is interactive and interesting for most of the patients, so that they are well complied with the program that can be implemented at home. Previous studies of home-based therapy of mirror therapy involved OT visit to patients' home. Examples include Yale et al. At Columbia University and Xie et al. At Changping University. Their home-based NT was implemented based on therapists visit to home, whereas our home-based therapy was established via video conferencing on Google Meet, and the work has been published in this year indicating the relevance, feasibility, and efficacy of video conferencing on Google Meet as a means to telerehabilitation for monitoring and guidance of home-based neurotherapy. In the article that we published this year, we used a randomized crossover trial to compare clinic versus home-based hybrid therapy involving neurotherapy preceding augmented reality. The treatment period lasted for 3 weeks before crossing over to the other study. The washout period lasted for 3 weeks. At the end of the treatment, there was a 3-month period of follow-up. At the end of the follow-up, we found that the clinic-based program seemed to be more beneficial for improving motor and balance function, whereas home-based sessions were more beneficial for improving patients' self-reported arm use in real-life situations. Practice context is important given the finding. Further research may complement clinic and home-based practice for optimized treatment gains, given the growing restrictions in outpatient rehabilitation in today's clinics in Taiwan. In our current study, as funded by the NHRI, we have been doing a randomized controlled trial comparing 3 groups, which included NT plus AR relative to AR alone and control therapy based on regular rehabilitation. The primary and secondary outcomes encompass relevant domains as addressed by the ICF in stroke. This flowchart indicated that so far we have recruited 15 participants for each group, with only 1 dropout for the CT group during the 3-month follow-up. For the AR protocol, there are different domains for interaction between the patients and the scenarios. The practice involves operating, learning, balance, posture control, mobility, and cognitive games, emphasizing memory, sequencing, sustained attention that are important for recovery from daily activities deficits. The preliminary finding indicated that differential benefits of NT plus AR relative to AR alone. NT plus AR might be more benefits in improving sensory and motor deficits at the end of the treatment and at 3-month follow-up. We are still recruiting additional participants for the ongoing study and will do the predictive study to identify responders versus non-responders in our trial. Ongoing studies needed that will focus on robotic therapy that can be versatilely changed to different protocols for the need of individual patients. For example, forearm emphasized robotics versus wrist emphasized robotics to address the needs of different patients with hemiplegia. We have computerized neurotherapy to allow better observation of mirror image during the imagination of arm movement. Both action observation and motor imagery are important ingredients of successful neurotherapy. We are trying to computerize the program so that conventional MT can be used in combination with the computerized system. Our secondary analysis of databases has been established based on the logistic and multiple regression model, indicating that several factors might be important for predicting the outcome. For example, gender, muscle strength, motor function, and self-perceived arm use could be predictive of treatment outcome. The finding indicated the importance of individualized assessment, addressing individual patient needs. We also have used the machine learning based on our cohort to establish the predictive models. So far, the preliminaries indicate that the best algorithms might include random forest and supervised machine. Machine learning might be advantageous to complement regression model for the predictive study. We thank the NHRI for the generous support over the 15 years to sponsor our core research projects on rehabilitation research. I'm also grateful to our dedicated colleagues who have been working so far and so dedicated to the accomplishment of the NHI research project. Thank you very much.
Okay, thank you. Any questions from the floor? Thank you for that very comprehensive review of the work. I had a couple of questions. One, you could address the adherence and retention differences between home-based versus clinic-based rehabilitation. And then thinking about the work that you've done, are you able to then identify which patients would be better served by home-based versus the clinic-based in terms of trying to have more precision-based rehabilitation for patients?
Given the current situations in medical rehabilitation in the outpatient department since the pandemic of COVID-19, the time for outpatient treatment is decreasing so that the patient needs to be guided for a better home-based program that might be feasible and effective to improve their treatment outcome over time. We have tried to complement clinic-based therapy with home-based therapy via Google Meet and other maneuvers so that the patient can practice at home under the online monitor of the therapist with the online and offline feedback on their performance so that the patient come back to the hospital for the review of their home programs and an update of their treatment goals. They no longer need clinical therapy at a medical setting. They play an important part in the recovery process by playing actively at home and the community. We found that it is a successful model to reduce the burdens of medical services and to allow the patients to be active in recovery from their stroke.
Okay, any question?
Dr. Lay, we appreciate your detailed psychometric analysis, and you utilize the heightened response theory as basis to detect the validity of the approach. I wonder whether you have utilized more confirmatory strategy that is to conceive as a multidimensional or cognitive assessment. Your cognition may be singular. You have 30 some items to measure, but I wonder whether this is a single dimensional or multi-dimensional scale.
Thank you. Clear as a question based on our preliminary analysis of the structure of the SSEQ, the self-efficacy measurement. We found that there was a bi-factor structure underlying the questionnaire. But given the limited sample size, our confirmatory factor analysis was preliminary. Now we are recruiting more participants to allow a larger sample for confirmatory study of the underlying structures using the IRT, RASH analysis, and other statistic models, including machine learning or deep learning.
Thank you. Due to the time constraint, we need to move to the next speaker. Thank you, Professor Lee.